Good morning friends, welcome to my channel Medics Tutorial, and this is the this is the seventh video of urinary system, and today's topic is the pharmacology of the urinary system. In this section you will learn about classes of drugs which mainly used for urinary dysfunctions or diseases. We'll see it as follows. Firstly, uh, diuretics or natriuretics are drugs which cause a net loss of the sodium and water in urine. However, when a diuretics is given regularly, sodium balance is soon restored with compensatory homeostatic mechanism of body with a certain with a certain degree of persisting deficit and reduction in fluid volume. Second is the antidiuretics or antiaquatics. Because they inhibit the water excretion without affecting salt excretion, are drugs that reduce urine volume, particularly in a patient with diabetes insipidus, which means the loss of water through urine. To, to prevent the loss of water in urine, will give antidiuretics to such patients, and its primary indications for such type of patients. In this slide, you'll see the classification of diuretics. After that, antidiuretics. First, we'll talk about the diuretics. It is divided into three subtypes: high saline diuretics and medium efficacy diuretics, and third one is the or the adjunctive diuretics. Here we'll talk about the high saline diuretics, which are the inhibitors of sodium, potassium, and chloride, which works by co-transport, which means moving the molecules in opposite directions. It includes furosemide, bumetanide, bu- bumetanide, and toracemide. Medium efficacy diuretics. These are the inhibitors of the sodium chlorides, which works by symport, which means moving of the molecules in same direction. So it again divides into two subclass: benzothiazines and the thiazide-like drugs. So first we'll talk about the benzothiazines. It includes hydrochlorothiazide, hydroflumethiazide, and benzthiazide. In thiazide-like drugs includes clothianidone, metolazone, zipamide, indapamide, clopamide. Now we'll talk about the weak or the adjunctive diuretics. It again divides into three subclasses. First is the carbonic anhydrase inhibitors, which includes acetazolamide. Second one is the potassium sparing diuretics, which divides into two subclasses. Firstly, aldosterone antagonist. It includes spironolactone and eplerenone, and the renal epithelial sodium channel inhibitors, which includes amiloride and trimethoprim. Lastly, the osmotic diuretics. It includes mannitol, isosorbate, and glycerol. Now we'll talk about the antidiuretics drugs. Antidiuretic hormone and its analog. It includes vasopressin or the ADH, which means the antidiuretic hormone, desmopressin, lipressin, terlipressin. Second is the natriuretics, which includes thiazides, and amyloid. Miscellaneous drugs are carbamazepine, chlorpropamide, and indomethacin. Earlier, we have seen the definitions of the diuretics, classification of diuretics. Now we'll see the site of action of diuretics. As you can see here, it's a image of nephron, which is structural and functional unit of the kidney. So we can see that diuretics mainly acts on a nephron, which which forms a excretory system of a kidney. So we can say that diuretics acts on a nephron by acting on its various components. Also, it can control its urine composition and urine volume. So diuretic acts on various components of the nephron, as you can see here. This first one is the glomerulus, second one is the proximal carbonated tubules, third one is the descending loop of Henle, fourth one is the ascending loop of Henle, distal carbonated tubule, collecting ducts. From collecting duct, it starts a collecting system of the collecting system of the urine system. So uh, it doesn't have the main effect any effect of diuretic on it. So we have to study up till now. So this is the collecting tubules. So we'll talk each diuretics one by one as mentioned in this image. So first one is the mannitol, which acts on the proxim mannitol, which acts on the proximal convoluted tubule and descending loop of Henle, which mainly responsible for the H2 reabsorption. After administration of the mannitol, it inhibits the H2 reabsorption, which increases the urine output or the urine volume. Now we'll talk about the acetazolamide. It acts on mainly on the proximal convoluted tubules. As you can see here, it's a pink. It is normally responsible for the bicarbonate and the sodium reabsorption, which is inhibited after administration of the acetazolamide. So instead of acidic urine will be alkalinizes. Loop diuretics. Loop diuretics mainly acts on a thick ascending loop of Henle and an proximal part of the descending convoluted tubule, as you can see here. I am highlighting, which is responsible for the sodium, potassium, and chloride reabsorption, which is inhibited after administration of loop diuretics. Fourth one is the thiazide diuretics, which acts mainly on the remaining part of the distal convoluted tubule, as I am showing here. Distal convoluted tubule normally responsible for the reabsorption of the sodium and chloride, which inhibited after administration of the loop thiazide diuretics. Lastly, sodium sparing diuretics, which mainly acts on the collecting tubule, as I am showing here, which is normally responsible for the sodium reabsorption and the potassium and hydrogen secretion. Both are get inhibited after administration of potassium sparing diuretics. That's it for now. Now we'll see all diuretics one by one. So first one is the mannitol. Mannitol acts on the proximal coronary tubule and the descending loop of Henle. Its mechanism of it is a osmotic diuretics which increases serum osmolality, leads to the fluid shift from interstitium to the intravascular space, which increase the urine flow and decrease the intracranial and intraocular pressure. Clinical use: it can be used in a drug overdose and elevated intracranial or intraocular pressure. Its side effects are dehydration, hypernatremia, which means low level or high level of the sodium, pulmonary edema, and it is contraindicated in anuria, patient who can't able to produce urine, and a heart failure patient. Acetazolamide, it is a carbonic anhydrase inhibitor which causes self-limited sodium bicarbonate diuresis and decreased total body bicarbonate stores, which leads to alkali alkalinizes urine, and it is used in glaucoma, metabolic alkalosis, altitude sickness, and idiopathic intracranial hypertension. Its side effects are proximal renal tubular acidosis, which is also known as type 2 renal tubular acidosis, paresthesias, which means pins and needles-like sensation, ammonia toxicity, sulfa allergy, hypokalemia, which means low level of potassium, promotes calcium phosphate stone formation, which are insoluble at high pH. This we can remember that aceta, acetazo, acetazolamide can induce acidosis as aceta, which we can say acid zolamide. Acetazolamide, also we can say acid zolamide, acid for acidosis. So acetazolamide can cause acidosis. Here we talk about the loop diuretics, which include furosemide, bumetanide, torsemide. Loop diuretics are the sulfonamide loop diuretics, which includes furosemide, bumetanide, and torsemide. Inhibits co-transport system of sodium potassium chloride, which acts on a thick ascending limb of loop of Henle, abolish hypertonicity of medulla, preventing concentration of urine, associated with the prostaglandin E, which is a vasodilator. It has vasodilatory effects on afferent arteriole, which is inhibited by NSAIDs, which leads to the increased calcium excretion. We can say you can remember it by mnemonics. Loops increase calcium. Loops increase calcium. It means furosemides, bumetanide, and torsenide increase the excretion of the calcium. It can be used in clinical conditions such as edematous states such as heart failure, cirrhosis, nephrotic syndrome, pulmonary edema, hypertension, or hypercalcemia. It has some side effects which we can remember by a mnemonic or dung. OHH, DAANG, Odang, O for ototoxicity, H for hypocalcemia, second H for hypomagnesemia, both are hypo, D for dehydration, A for allergy of sulfur, A for alkalosis, metabolic alkalosis, N for nephritis, interstitial nephritis, and lastly the gout. Now we'll talk about the ethacrenic acid, which is a non-sulfonamide inhibitor, which is also a co-transport system of sodium, potassium, and chloride, which also acts on a thick ascending loop of Henle. See, loop diuretics includes furosemide, bumetanide, and torsemide, which are sulfonamide loop diuretics. Ethacrenic acid is a non-sulfonamide inhibitors. Please do remember, both are a cotransporter system which acts on a thick ascending loop of Henle. Now, ethacrenic acid clinically used in diuresis in patients allergic to the sulfur drugs. Its adverse effects are similar to the furosemide, but it is a more ototoxic. Thiazide diuretics. It includes hydrochlorothiazide, chlorothiazidone, meto, metolazone. It inhibits calcium chloride reabsorption in DCT, which leads to the decreased diluting capacity of nephron, which as a result low calcium excretion. It is clinically used in hypertension, heart failure, idiopathic hypercalciuria, nephrogenic diabetic insipidus, and osteoporosis. Its adverse effects are hypocalcemic metabolic alkalosis, hyponatremia, hyperglycemia, hyperlipidemia, hyperuricemia, hypercalcemia, and sulfur allergy. Potassium sparing diuretics. This includes spironolactone, eplerenone, amiloride, and triamterene. You can remember it by mnemonics. Keeps your seat. Seat is our mnemonic. S for spironolactone, E for eplerenone, amiloride, and tri- triamterene. Spiro, spironolactone and eplerenone are competitive inhibitors, competitive aldosterone receptor antagonists in cortical collecting tubules. As you can see, there is a one ONE1 in spironolactone, and also it is present in eplerenone and aldosterone. So we can say that you can remember on the basis of one spironolactone and eplerenone are competitive aldosterone receptor antagonist in cortical collecting tubule. Triamterene and amiloride block sodium channels at the same part of the tubules, which is the collecting tubule. It can be used. It can be clinically used in hyperaldosteronism, potassium depletion, heart failure, hepatic ascites, especially spironolactone are used in hepatic ascites, nephrogenic diabetic diabetes insipidus. Amylorides are used in nephrogenic lactis insipidus, anti-androgen used spironolactone. It, it also has some side effects or adverse effects such as hypercalcemia. Hyperkalemia can lead to arrhythmias. Endocrine effects with spironolactones such as gynecomastia, anti-androgen effects, and metabolic acidosis. Now we'll see effects of diuretics on electrolyte changes. Firstly, urine NaCl. It increases with all diuretics. Urine potassium. It increases especially with loop and thiazide diuretics, excluding potassium-sparing diuretics. Blood pH. It decreases with carbonic anhydrase inhibitors and potassium-sparing diuretics. It increases with loop diuretics and thiazides in several mechanisms such as volume contraction. Potassium loss leads to the potassium exiting all cells. In low potassium state, hydrogen rather than potassium exchange with sodium. Urine calcium increases with loop diuretics and decreases with thiazides. Angiotensin converting enzyme inhibitors. It is the third class of the pharmacology of the urinary system. It includes captopril, enalapril, lisinopril, and ramipril. It inhibits the angiotensin converting enzyme, which leads to decreased angiotensin II, which leads to decreased glomerular filtration rate by preventing constriction of the efferent arterioles, which leads to increased renin due to loss of negative feedback. Inhibition of the angiotensin converting enzyme also prevents inactivation of the bradykinin, which is a potent vasodilator. It is clinically used in hypertension, heart failure, proteinuria, diabetic nephropathy. Also prevent unfavorable heart remodeling as a result of chronic hypertension. In chronic kidney disease, example diabetic nephropathy, decrease intraglomerular pressure by slowing glomerular basement membrane thickening. It has some adverse effects which we can remember by a mnemonic catch CATCHH for C for cough, A for angioedema, T for teratogen, C for increased creatinine, H for hyperkalemia, and second H for hypotension. It can be used with caution in bilateral renal artery stenosis because acetylcholine converting enzyme inhibitors will further decrease glomerular filtration rate, which leads to renal failure. Angiotensin II receptor blockers. It includes losartan, candesartan, valsartan. It is a selectively block binding of angiotensin II to the angiotensin I receptors. Its effect similar to the angiotensin converting enzyme inhibitors, but angiotensin receptor blockers do not increase bradykinin as ACE do. It is clinically used in hypertension, heart failure, proteinuria, or chronic kidney disease like diabetic nephropathy. Also it is used in intolerance of the acetylcholine angiotensin converting enzyme inhibitors, which can be shown by cough or angioedema. It has some adverse effects such as hyperkalemia, decreased glomerular filtration rate, hypotension, and teratogen. Now we'll talk about the L-scarin. It is a direct renin inhibitors which blocks conversion of the angiotensinogen to the angiotensin 1. Also, we can remember it by mnemonics. Aliskiren kills rin. How aliskiren kills rin? It's a direct rin inhibitor. It can be used in hypertension. It has some side effects or adverse effects like hypercalcemia, hyperkalemia, decreased glomerular filtration rate, hypotension, angioedema, and it is relatively contraindicated in patients who are already taking AC inhibitors or ARBs and contraindicated in a pregnancy. Here we end with the pharmacology of the urinary system, and also we have finished all video lectures of the urinary system regarding its embryology, histology, physiology, pathology, pharmacology, everything. If you have missed any of these, please do watch it. Thanks for watching. Like, share, and subscribe.